Dear colleagues, today we are presenting a case of prenatal diagnosis of vasa previa. This highlights the importance during ultrasound screening examinations of always assessing the site where the umbilical cord inserts into the placenta. In fact, as you can clearly see here, there is definitive evidence of an abnormal cord insertion, which in this specific case occurs entirely outside the placenta. So we are really talking about a velamentous cord insertion. Why is it absolutely critical to diagnose this? Because this represents the primary risk factor for the presence of vasa previa, which is accurately diagnosed using transvaginal ultrasound. As you can see in a sagittal section of the uterine cervix, the presence of umbilical cord blood vessels running in close proximity to the internal cervical OS is clearly visible. It is critically important for clinicians to carefully distinguish the potential presence of umbilical cord loops that may be transiently positioned in this specific area, but which do not necessarily represent vasa previa. Instead, in this specific case, we see that not only are they completely fixed and non-mobile, but above all, they are firmly attached and integrated into the myometrium. And therefore, in this clinical scenario, the diagnosis of vasa previa is exceptionally clear and definitive. Even when we are not utilizing color enhancement, but relying exclusively on standard 2D imaging, we can clearly see how these structures are firmly and entirely adhered to the wall and simply cannot be separated. This serves to emphasize the critical importance during the second trimester screening ultrasound, even though it is not currently mandated or recommended by standard clinical guidelines of using transvaginal ultrasound, not only for the detailed assessment of cervical length and thus clearly for preterm birth screening, but also to specifically rule out the presence of vasa previa. It is vital for us to keep in mind the fact that unrecognized vasa previa during the second or third trimester of pregnancy carries an extremely high risk of fetal mortality, as it progresses in a completely asymptomatic manner but can, in the event of labor or the spontaneous rupture of membranes, cause massive fetal hemorrhage and consequently severe fetal neurological damage, profound anemia, and metabolic distress up to and including death. Looking at these additional images, you can clearly see the vessel with the velamentous insertion. It then runs completely free of Wharton's jelly and the protective membranes near the internal cervical OS. Clearly, with the transvaginal approach, we did not clearly identify the velamentous insertion. It was much clearer with the transabdominal approach. However, if a careful study of the placental cord insertion is performed, this diagnosis can be easier and, above all, accessible to everyone. So, vasa previa can be classified into three distinct types. First, we have type 1 vasa previa, which are those cases, much like the case under discussion here, associated with a velamentous cord insertion, where these vessels run less than 2 centimeters from or even directly over the internal cervical OS. Again, you can see this in the second image check, which shows type 2 vasa previa. These are the ones associated with the presence of a succenturiate placental lobe, and this serves to emphasize and highlight the critical importance of studying the placenta during ultrasound. Because identifying a succenturiate placental lobe always requires a thorough and meticulous evaluation of the umbilical cord precisely to rule out the presence of vasa previa. Furthermore, we then have type 3 vasa previa, which are actually a rather rare entity, specifically associated with the presence of a normal placenta with a cord insertion and a single loop of abnormal vessels, which, originating from the placenta, run near the internal cervical os and then return close to it. The main clinical guidelines regarding the management of vasa previa recommend considering elective preventive hospitalization starting from the 32nd week of pregnancy. In reality, this is especially related to the patient's clinical history and the possible presence of risk factors for preterm labor. For example, a positive history of preterm birth or a multiple pregnancy or the presence of symptoms such as uterine contractions could require preventive hospitalization. This may be used in conjunction with a course of corticosteroids to promote lung maturity, beginning as early as the 32nd week, specifically due to the significantly increased risk of a preterm birth. Furthermore, the primary clinical guidelines and medical protocols always recommend that delivery should take place, as they say, between the 34th and 36th weeks of gestation. In reality, some medical guidelines explicitly state that in the absence of risk factors, delivery can also be successfully performed by a planned elective cesarean section procedure from the 36th week onward. Thank you all very much for your kind attention today.